Good afternoon, ladies and gentlemen. My name is Shane Coleman from News Talk Breakfast. We're delighted that you could all be with us for this combined in-person and online event. It's great to welcome delegates from across higher education, government, and indeed the health sector. For those of us joining online, we have closed captioning available today. You can alter the size of those captions by clicking on that CC button at the bottom of your screen. We have a great lineup of speakers and panelists for you today. Our keynote speaker is Stephen Donnelly, Minister for Health. Minister Donnelly will share his views on workforce planning and future skill needs of the health sector, and indeed the role of the university sector in producing the talent and the skills pool for health going forward. We also have a great panel for you to tease out these issues with. Our panelists are Professor Orla Shields, Trinity College Dublin, Professor Stephen Byrne, University College Cork, and Sheila McClelland, Nursing and Midwifery Board of Ireland CEO. We'll also get some closing remarks from Jim Miley, who of course is Director General of the IUA. But I'd like to formally introduce our guest speaker today. Stephen Donnelly was appointed to, I suppose, what is probably the most challenging job in Irish public life, that of Minister for Health. He was appointed in June 2020. He's been a member of Dáil Éireann for over a decade, elected as an independent in 2011, joining Fianna Fáil in 2017. He graduated from UCD with a degree in mechanical engineering. He holds a master's in public administration and international development from the Harvard Kennedy School. He has worked, as I'm sure you're aware, across many sectors: private equity, retail, public infrastructure, healthcare, education, international development, and the voluntary and social sectors. In short, it's a pretty impressive CV. Ladies and gentlemen, give a warm welcome to Minister Stephen Donnelly.
Good to see you. They're the nicest word Shane has ever said as an introduction to me before. Usually it's, and now we have Stephen coming on and we're going to ask him some very difficult questions about why everything is going so badly. So it's lovely to, it's lovely to hear that. Thank you so much. So good afternoon, everybody. I'm delighted to be here, and I know we've got several hundred people watching online. A mass of very clever people, many with more letters after your names than before your names. It's lovely to be here. Can I thank Jim Miley, your Director General, for the invite, and I'd like to acknowledge my fellow panelists. I'm looking forward to the discussion. Professor Stephen Byrne, Professor Orla Shields, and Sheila McClelland as well. I'm delighted to be joining all of you on the panel. I want to start by commending all of you in the Irish Universities Association and right across the higher education sector here for your ongoing contribution to higher education, which to me is a priceless contribution to our country, to healthcare, to our society, and to our economy. It's essential, as you all know better than anybody, that Ireland has a world-class university sector. We do not strive to be okay or good. We must and do strive and succeed in being seen around the world as having one of the best education systems, higher education systems anywhere in the world. And you can see the results of all of your effort and passion and skill and hard work in our healthcare professionals, our nurses, our doctors, our dentists, our pharmacists, our health and social care professionals, being viewed right around the world as some of the best trained, some of the best educated, some of the highest skilled healthcare professionals anywhere in the world. And that's thanks to all of you. It cuts both ways. It means we have the great great opportunity of having such a pipeline of healthcare professionals coming into our health service. But it also means that lots of other healthcare systems come here looking to entice them and sending them billboards of Bondi Beach and all manner of outdoor pursuits and so forth. But thank you for everything that you do. It is greatly appreciated. So today, obviously, we're talking about developing future skills for the health sector and future skills needs for the health sector. So I'm going to boil this down to three things. Number one, we need to double the number of healthcare college places in Ireland, and we need to do it fast. Number two, we need to educate our students to the highest possible standards and make sure that that includes equipping them for the future. Make sure it means that they are proficient in digital technologies, artificial intelligence, genetics, personalized medicine, and all of the rapid, very exciting changes that are happening in healthcare. And number three, we have to make sure that our students have a positive experience through their education and through their training, so that they, first of all, decide that they're going to continue as healthcare professionals when they graduate. And secondly, that they spend the majority of their healthcare careers here in Ireland. I would encourage everyone to go abroad and live abroad and see the world and get international experience. But ultimately, we want people choosing to come back to Ireland. And part of that is making sure that they leave your institutions with a positive impression, not just of being healthcare professionals, but of being healthcare professionals in Ireland. Our goal is universal healthcare. It's one of the most important and unfinished projects of our republic, enshrined in the 1916 proclamation, which declares that the nation and the republic must cherish all of the children equally. So what is universal healthcare? It's very simple. There's three tests. Is healthcare affordable? Is healthcare high quality? And can you get it when you need it? They're the three tests. And so what I've been doing and what government has been doing for the last 3 years is marshalling the resources of the state and marshalling the healthcare apparatus of the state to achieve those three goals: cost, quality, and access. When it comes to cost for patients, you'll see we've introduced free contraception. We're introducing state funding for IVF. We have abolished inpatient hospital charges. We have reduced the drug payment scheme. We'll shortly be rolling out about another 400,000 GP cards. So we're quite radically reducing costs for patients. That's test number one. Test number two is, are the services there that patients need? So we're expanding services. What does this mean? It means fully funding our national strategies for the first time. What does that mean? It means new services in cancer care, in stroke, diabetes, mental health, home care, ambulance services, dementia care, obesity, cardiology, COPD, genetics, and lots more. There's a lot more available to patients now all over the country than there was even just 3 years ago. And as those strategies continue to get funded, more and more essential services are coming online. You'll be aware, hopefully, that I prioritized women's healthcare and said we need a revolution in women's healthcare. We don't need things to get a little bit better each year. We need to address a fundamental, historic, gaping deficit in our country, which is we never provided women's healthcare services at the level we needed to do. So we have been pouring resources into women's healthcare, and the result, thanks to the extraordinary work of healthcare professionals around our country, has been very, very encouraging. We have built from scratch a new network of see and treat same-day gynecology clinics. Maternity care is getting better. We now specialist menopause services, specialist endometriosis services, contraception I talked about earlier on. We're expanding fertility services, perinatal mental health services, mental health support teams for eating disorders, and more. So we're rapidly building up the services required in terms of women's healthcare. So that's the second test. Are we providing the services that patients need, and are they consistently high quality services? The third is the most difficult, which is access. Can you get access when you need it? So to that end, we've been tackling the waiting lists. We know they were far too high before COVID arrived here. COVID made them worse, but we have allocated a vast amount of resource and public money and effort and attention in government, in the department, in the HSE to this. And the results are encouraging. There is a long way to go, but for the first time in a long time, the waiting list began to fall at the end of 2021, when we finally got a bit of breathing space from COVID. Last year was the first year the waiting lists fell since 2015. This is going to be the second year. Next year will be the next year. And we are beginning to get on course now to achieving the Sláinte Care targets of no patient waiting more than 10 or 12 years. So we're cutting costs, we're rolling out services, and we're fixing the waiting lists. And because of all of that, because of the efforts in every hospital and every community care setting in the country, we are now, for the first time since the foundation of our republic, within touching distance of this cornerstone, I would say, of a civilized society and of our republic, which is universal healthcare. So it's a very exciting time. We're not there yet, but we are clearly moving in the right direction, which is fantastic. So how is it happening? We have a two-part strategy. We have a strategy of capacity and reform. and moving radically on both. So on capacity, over the last 3 years, we've increased the healthcare workforce by 21,000 healthcare professionals, and thousands more will be added this year, and then hopefully next year, pending my conversations with Pascal Donoghue and others. We've added about 1,000 beds. There's another 300 or 400 coming through the pipeline now, and I'm seeking agreement on another 1,500 through a rapid build program. We have 4 new hospitals being progressed. Now, the National Children's Hospital was the only hospital built by the state for a very long time. In this government, we're moving forward on four new ones. We've increased critical care capacity. We've increased community beds. We've increased diagnostics. So capacity is being expanded at an unprecedented level. But on its own, that isn't enough. Because we have to have fundamental reform and modernization in how the care is delivered. So to that effect, we have the new public-only consultant contract. You'll have heard, hopefully, Bernard Gloucester and I talking about moving from a broadly 5-day-a-week service to a 7-day-a-week service. We've built up an entire new community healthcare service that didn't exist 3 years ago. 96 primary care teams, specialist teams all over the country. We're pulling GPs into the center of care more and more, with access to diagnostics, access to specialists, the chronic disease management programs, and more. We're establishing the regional health areas. In the next few months, we'll now be hiring the regional chiefs for the 6 regions, and then we'll be building the teams. Around them. We're investing in elective-only hospitals, which are going to fundamentally change how the hospitals with emergency departments work. We're investing in e-health. Ireland is a laggard in e-health. There is a huge piece of work and a huge investment required for all of that. So that brings us to today. That's what's been going on over the last 3 years. But in spite of an unprecedented increase in our healthcare workforce, there is much more we need to do. In fact, what we need is a fundamental structural reshaping and increasing of capacity within the higher education sector to provide what's needed. We need to double the number of healthcare college places. So to put that in perspective, we have about 2,000 entry-level nursing places each year. That needs to hit at a minimum 4,000. That is a big, big structural change. We need it in medicine, health and social care, dentistry, pharmacy, right across the board. Now, the good news I met with several of the universities, including some of the people here today last year, to say, this is what I think is needed. This is what the analysis shows we need. We are far too reliant on hiring healthcare professionals in from abroad. We must be self-sustainable. And the response was very positive. A lot of excitement, a lot of passion for doing it. They immediately said, as they should, we need loads more money to do it. We need new buildings and new staff. I don't think I've ever come out of a hospital without being asked for at least 20 or 30 million euros. So I was happy to see that the senior leadership within the university system is on message as well in terms of needing new funding. But of course you do. We need new buildings, new teams, new IT infrastructure, new simulation suites, and lots more as well. But the passion and the appetite was very real, not just in expanding the courses, but in innovating and making sure that we are training graduates, not just for healthcare today, but for the healthcare we're going to have in 5, 10, 20 years. So following that, I engaged with my cabinet colleague, Minister Harrison. We engaged with his department to say, look, we've met the universities, they're up for this. This is a national strategic imperative. This must happen. Can you now work with the HEA and the various institutions to start putting a credible plan in place? And so that is the work that has been going on. The easiest win is medical places. We don't actually need a single extra medical place in the country. Ireland has the highest medical places per capita of any country in the OECD, and yet we have a deficit of doctors. The reason we have a deficit of doctors is because 46% of the medical students come from outside the EEA. In and of itself, that's fine, but we have data that shows very clearly that they don't stay here. So in CUH, for example, they train a load of Canadians, which is fine, great country. And I'm sure they train some of our doctors, but we have to be more strategic about how we deploy our resources. So the easiest thing to do is simply to shift the balance from EU, UK, EEA, increase that to make it more balanced and more sustainable. Now, We all know why it is out of balance at the moment. There was a funding deficit that universities were left with. The universities responded as they needed to do to plug that deficit. So I say this fully in the knowledge that we need to provide that funding from the state. We can't ask you to just do it. You can't do it. You'd run into deficits if you did, but it is the single easiest win. And certainly from my perspective, we need to allocate training places for training doctors in the HSC to reflect that balance. It is simply not sustainable for us in the coming years to provide training places in a way that is so imbalanced. So we will adapt our training places. Accordingly. So last year, Minister Harris and I, we reached an agreement with the schools to increase places for the EEA students by 200 by, I think, 2026. So the agreement began with 60 students last year, another 60 this year, and up to 200 by 2026. The agreement is welcome, but it's not enough. It's not even close to enough. And so that conversation needs to continue. Again, we have to set the target of doubling the number of EEA students we have in our medical schools, and we need to start bringing that about quickly. Postgraduate training for doctors is something the university said they're very, very interested in. It's a shorter course. It's more aligned to the US system, where you do your primary degree and then you go on to medical school. And what the regional universities are saying to me is they're finding that the people who train at a postgraduate level tend to stay in the area. They're a bit older, they might have family. So if they're training in Limerick, or they're training in Cork, or they're training in Galway, they are less likely to then move to Bondi Beach with their children afterwards, and more likely to take a job in one of our hospitals. And so the universities were very keen on that. We had 2 years ago about 3,800 consultants in the country, a low level by OECD standards. I've set a target of moving from 3,800 to 6,000. So that's more than a 50% increase in consultant posts. We're now at 4,200, so we're moving in the right direction. The new consultant contract, by any reasonable measure, is a very attractive contract, and the HSC is now advertising around the world. Anecdotally, I'm hearing people are interested. I was listening to some BBC Northern Ireland yesterday in light of the announcement around our funding of nursing places. And one of the points made was that consultants in Ireland under the new contract will be paid about twice what they're paid in Northern Ireland. It's a very, very attractive contract, and we must keep our eye on the prize, which is to get to about 6,000 consultants. We have far too many non-training NCHD posts. We are too reliant. We have a hospital system that relies on nurses and junior doctors and doesn't have enough hospital consultants. We have far too many non-training posts. It's not fair on the doctors there. Any junior doctor, any NCHD in our system deserves the right to train up to consultant. Doesn't mean they all want to, but they should all be given the opportunity to do that. So we need to radically reduce the non-training posts and increase the training posts. And so to that end, my department has been working with the HSC and with the universities on that. There's been a 21% increase and a 27% increase, which is over the last few years, in the initial specialist training and the higher specialist training posts. So that is happening. We're also working with the ICGP, who deserve huge credit. We're tripling the number of GP training posts. In 2009, it was 120. By next year, it'll be 350. So we are fundamentally changing the pipeline of GPs coming into the country over the next few years. The biggest challenge is probably nursing. Last year, about 1,500 Irish trained nurses and midwives registered here. Vast majority of them took up posts with the HSC, and it was very encouraging to see. But we need a lot more. As I said, we need to move from about 2,000 incoming college places to about 4,000. And that can be graduate and undergraduate. And again, my discussions with the universities show that they were very interested in the graduate nursing training places as well. We've got to be open. We've got to be open to innovative solutions. You'll have seen the recent agreement with Northern Ireland. And Minister Harris and I, in terms of the future of nursing and midwifery, recently agreed to develop out these other roles. So graduate training posts, apprenticeship posts. We may end up with a different name for them, but critically, any vocational route must be linked to a level 8 qualification as well. The nursing degree is absolutely central to all of the developments we have going on in nursing and midwifery. One of them is advanced practice. I think it's one of the most exciting things happening in terms of the evolution of the workforce. We have advanced practice nurses and midwives, and as word has got out around the system as to just how much work these advanced practitioners can do, the demand is heating up. What they're able to do, they're autonomous clinicians. They're able to see, diagnose, treat, prescribe, discharge, refer for radiology patients. And we're seeing that they're able to take on a good number of patients who traditionally would have had to wait to see a doctor. In some cases, they might wait to see a year, or might have to wait a year to see a doctor. You can see an ANP much quicker. So that's something that we need to see move along. The other big group that gets much less attention than it should and that it deserves is health and social care professionals. It is a more complex group because there are so many, but we have to have the same level of ambition. We have to double the number of health and social care professional roles across the country. We're also now developing advanced practice in health and social care, things like physios being able to refer for radiology, autonomous clinicians right across the board. And I've appointed a fantastic new Chief Health and Social Care Professional Officer to the department. She started about 2 months ago, I think, has hit the ground running. And we're going to bring a level of development and focus now that our Chief Nurse, Rachel Kenna, has brought to nursing and midwifery. Delighted to say that we have passed the 1,000 mark in terms of advanced nurse practitioners and midwife practitioners. The original target was 2% of the workforce. We moved that to 3%. I've now moved that to 5%. So the highest rate in the world is the US, they're at 5%. So our ambition is to become world leaders in this. My hunch is when we get there, we'll move on. Based on everything I've seen about the scope of clinical practice that advanced practitioners can do, I imagine we'll be at 10% of the workforce in years to come. And I see no reason why that wouldn't be applied to health and social care professionals as well. So thank you. That was a whistle-stop tour. I appreciate I was covering a lot of ground, but just to recap on what we need to do, in my view, we need to double the number of healthcare college places, and we are on our way. We need to make sure that we are graduating students who are future-proofed and who have the ability and the ambition to work to the very highest extent of their license and to continue training and master's degrees, continuous professional development to extend and expand their scope of practice. I think that's what we need to do. And then finally, we have to make sure that they have a positive experience. Doesn't mean that it doesn't have to be hard and challenging. But for example, if we look at NCHDs, now I know that's not the university sector, but they're still doctors in training. The lot of the NCHD is completely unacceptable. It's very damaging, it's very foolish. And so we're doing an awful lot of work now. We put a working group together to fundamentally change that. So we've got to make sure that our graduates, when they leave nursing school or they leave medical school or they leave health and social care professional school, that they want to be healthcare professionals, and they may want to go and live in Bondi Beach for a year or two, and best of luck to them. But that ultimately they know that working in healthcare in Ireland is a rewarding experience where they are valued and respected and supported, and that they will come back here and take care of all of us when Shane and I are retired. Thank you. Thank you all very much.
Yeah. Ooh, excuse me. Thank you indeed, Minister. Yeah, you covered a huge amount of ground there, really interesting and clearly a lot going on. The Minister is staying with us for our panel. Can I invite the rest of our panel members to the chairs? We're joined by Professor Orla Shields, Vice Provost and Chief Academic Officer of Trinity College Dublin. We also have Sheila McClelland, Nursing and Midwifery Board of Ireland CEO, and Professor Stephen Byrne, Deputy President and Registrar of University College Cork. By the way, if we have time, if you do want to answer a question, if you have a burning desire to answer a question here, just stick your hand up and I will come to you and we'll try and get some questions in a little bit at the end. Guys, you're all very welcome. Thanks indeed for joining us. Let's start with the issue of obviously, we need to increase the level of people. You mentioned doubling the number, Minister. So we need to, I think everyone would agree, address the issue of insufficient clinical placement for students and trainees across all healthcare professions. Orla, I might start with you first. How do you address that?
Okay, I think what's really needed is some joined up thinking between the different departments. So from the education or from the university's perspective, we can take increased numbers of students, but unless we match them with supervised places in the clinical setting, that's the logjam. And so there does need to be, there hasn't been that joined up thinking, I would say, which allows for practice trainers to be in place, enroll in their hospital or their clinical setting to train those students who've come through the academic part of the course and now need to upskill with clinical activity. And so it's a more integrated approach, I think. And then as we increase numbers further, I think we need to look at the areas that don't currently look after our training students. And that's possibly because they're single practitioners in a particular practice, or they might be in a more rural area. And the regulatory system means that they may not have sufficient capacity to train students. So we need to look at that if we've got to meaningfully upscale the sort of numbers you're talking about.
Okay, Stephen, I think I'm right in saying your sort of pharmacy background. Am I right in saying pharmacy is actually quite good in this area, or are you going to correct me on that?
We can be better, but we are good.
Yeah.
Yes, I am a registered pharmacist. I was head of school of pharmacy when the legislation was amended in 2014 by the now Taoiseach, which required the integration of work experiential learning into a degree, into an integrated practice. And we looked at the opportunities to widen the scope of experiential placements, and we doubled the number of experiential placement opportunities. And I have to say that where we have the least number of places is the HSE. So we have broadened our places. We have worked with the regulator to identify and to recognize various types of placements, including international placements. Up until that point, a placement anywhere in Europe wasn't recognized by our regulator, where they now will recognize 4 months of that training being done in Europe, which is a hugely valuable and beneficial experience for anybody in any healthcare profession to actually see how another jurisdiction works. So we work collaboratively with the placement providers, with the educational institutions and the regulator. So a three-pronged approach, or a three-pronged stool, and got everyone at the table. We work collectively as the educators in Ireland, and we set up a shared services office to facilitate those placements. But to this date, the least number of placements provided are in the HSE, and there's huge opportunity there for us.
Why is that?
There was industrial relations issues with the HSE that the university.
Isn't there always with the health sector in Ireland?
That the universities weren't part of.
Yeah.
But they are coming to resolution, which is positive. And I see huge opportunities. Minister knows that we, as a sector, an expression of interest has come out to expand the places. We have risen to that opportunity. We await the outcome of that opportunity. But I think working as a tripartite approach, the regulators, the educators and the HSE, or the Department of Health. That's where we need to work collectively together on shared services and shared vision, like Orla said, joined up thinking.
Okay, Sheila, do you want to give us the nursing context here?
Yeah, well, as Minister Donnelly has said, you know, we've been mobilised and in a state of sort of high alert, if you like, for since COVID. And we've been looking for additional capacity, and we actually found some additional capacity even in the COVID period. We were able to put some more students into the first year of the programs. But to do that, we've had to really work in a very collaborative way. So the HSE is working very closely now with Department of Further and Higher Education to look for those spaces. So the group directors of nursing in the country have got together, and they actually were able to identify potential capacity this year for 400 additional undergraduate places. Well, that's really exceptional, because if you're in hospitals, they're under pressure. We're bringing in a lot of overseas nurses. They have to be adapted. So there's a lot going on. So to actually be able to identify that capacity, some of that was enabled in the middle of the crisis, because we were able to look at capacity and say, where could we put them? Where can we find new space to put people when we were up against having the places in those years when we were actually having to maybe take students out for a couple of weeks. Mm-hmm. So how are we going to make up the difference? And we had to think wider. So advanced nurse practitioners became somewhere we would locate nurses, students and midwifery students. The difficulty is that, you know, it's difficult for the universities then. If you're working in big numbers of students to use small places that can only take small numbers of students becomes much more logistically challenging for the universities to do
and it's
that.
only going to get more challenging.
Absolutely.
Is it
And you
4,000?
need the clinical trainers in those sites.
Yeah.
Yeah, and also then we have to introduce the community. If we're going to launch care models, there's going to be a lot more activity going on in the community. And the model at the minute of funding perceived by the universities, which is more or less right, is that the money goes to the acutes for the support and it doesn't go into the community. So we have to find some way to sort of, it can be addressed, but it's perceived as a bit of a block at the minute, but that can be addressed.
Okay, Minister, food for thought.
Yeah, so the training places is resolved. There is no training place issue. When you come to medical places, remember, we're not looking for any extra students. We just want the students to be EEA. So there's no additional capacity required for that. As Sheila said, on nursing, we have created 400 additional just for this September. Now, I don't think we get 400 extra college places. So we have more provision than we need in terms of training places. Pharmacy, we look into. There's been a very positive response to the expression of interest in terms of pharmacy. It's been really good to see. But certainly in terms of the pipeline now, training has been resolved. It's not an impediment.
Okay. Yes, Stephen.
Yes, there has been significant steps forward in the provision of training places, but we still need to have the provision of clinical tutors for physiotherapy, for occupational therapy, speech and language therapy. We need dedicated tutors in the clinical sites who have the responsibility to oversee the training of the students. So there may be a willingness to take on the placements, Minister, but there isn't dedicated staff with that role in the sites to take on.
Regulator mandates that they be in place. So it is an issue that causes stasis.
Not in nursing, it's not. I mean, as Sheila said, we have created the places. Like the first came back to us and said, the blockage is training places. We went and comprehensively resolved the problem.
So
As Sheila has said, Sheila's the head of the NMBI. Like we have hundreds of places ready to go in terms of capacity. We just need to fill them.
Okay, all right. Minister, can I stay with you for a second? You kind of touched on this in your opening remarks. Obviously, we need to recruit more students, and you've spoken about that. But how do you slow that rate of attrition of people who are working in healthcare? How do you make sure, as you say, not only do they want to come back here, but when they're working here, they don't get burned out, they're not exhausted, they actually want to stay working here?
I think there's a bunch of things you have to do. I think part of it is structural. You have to make sure that they have the basic tools that they need to train. Right? These are training posts. So if you take some training posts, they didn't have basic access to some basic things like lockers, somewhere to park or put a bicycle, somewhere to hang up a wet coat. So some of it is basic infrastructural improvements which need to be made. They are being made, but they're not all there. Partly it's cultural, and it is different profession by profession. So generally, the student nurses I meet around the country, the vast majority of them love what they're doing. They love they love their university education. They love working in the hospital. Not all of them. They don't all have a good time, but most of the ones I talk to have a really positive experience. And the universities and the NMBI and the HSE work really closely to have this very structured team in place to support the student nurses. Talk to the medical students is very different. There's a different culture. There's a very outdated culture, which essentially says, well, I had an awful time and had an awful time as an NCHD. And so we will be perpetuating
so the people behind me are bloody well going to have an awful time as well.
Yeah, there's a bit of that. And expectations have changed quite rightly. So our NCHDs and our medical students, there has to be a change of culture within our hospitals. And as Sheila said as well, what we're beginning to do now is move beyond the hospital, because as we move to the regions, the whole point of regional healthcare is to get away from this idea that there is a hospital system and there's a community care system. There is a single health service.
Sure.
And we need to be rotating our nurses and our doctors and our pharmacists and our health and social care professionals through both. So there are structural things we can do. There are cultural things that we need to do as well. And as I say, it's different for different professions.
Quite a challenge changing the
Yeah.
culture in the health sector, I imagine. Or like, what can universities do on this issue?
So there are a number of things. I mean, the first thing I would say is that as we move to more community-based healthcare delivery, we need to recognize the isolation that some practitioners feel. So while I applaud the initiative to have more students coming in through our system, we need to look at the other end of that spectrum and see what can we do to keep people who are trained active and engaged within the system. So more engagement and more community support for those isolated practitioners. I would suggest in the hospital setting, you know, people don't necessarily abandon ship as NCHDs just because they've had a bad experience. They look down the line and they see what's in front of them. And we've seen certainly in my own university and partner hospitals, the benefits that can be accrued from having some portion of time bought out for a practitioner so that they can do research, they can continue to engage with academia and therefore provide the most cutting edge healthcare. But that amount of headspace, we will attract more people back if they aren't seen to be just helping cogs in the machine turn, that they can contribute and use the intellect that they've gained in international centres like Johns Hopkins, Memorial Sloan Kettering, and bring that back here. Those people will only do that if we can allow them to continue at that forefront of research and academia and support them in doing that.
Okay, makes sense. Stephen,
Yeah.
do you want to come in on this?
Yeah, I think there's an opportunity as we move towards the primary care and sláinte care model. I think we can take the model of the multidisciplinary team approach from secondary care into primary care and develop networks where you have your fellow healthcare professionals working collaboratively, collectively together on case conferences, and they support that network and that mentoring for each other. Building on Orla's point there as well, again, allowing staff in the primary care and sláinte care some allocated time to be practice educators, to come into the universities and actually deliver teaching material. So they link with fellow professionals, and in a multidisciplinary environment, there's huge opportunities as well with advanced practice roles, which we might talk about later on.
Okay. Minister, I'm just curious, collaboration, multidisciplinary approach, is there the appetite in the health service to do that? I mean, that kind of happened during COVID. COVID seemed to break down a lot of those traditional barriers.
Yeah, I mean, this is where we're moving. So I fully agree in terms of research and development. So the new consultant contract has €20,000 per year per consultant to do local R&D, local innovation, clinical trials, any work they want with universities. 20 grand a year, like it's huge, right? We've made it clear in the contract that it is more flexible than the previous contract. People might want to do 1 day a week in academia, or they may just want to work 3 days a week because they have kids, or they just want to work 3 days a week. So all of that is catered for in the new contract. It's a much more modern, reasonable approach in terms of workforce. So
could the 7-day week, and I want to ask you about that a little bit later, but could that actually be a little bit of a barrier to that? Might people going to go, you know what, I don't want to be working Saturday and Sunday. I'm going to stay in Australia or wherever, where I don't need to do that.
Yeah,
I understand why you want to get to that point, but could it be a barrier?
It will be for some, but it won't be for most of the healthcare professionals I talk to, right? You talk to anyone working in an emergency department and say, what's the single biggest solution to your problems? They'll say, the system working on a Saturday and a Sunday. They have to be able to discharge their patients. They need access to radiology. They need access to all sorts of stuff that they don't have. You talk to the nurses, they'll say, well, they're already rostered 7 days a week. Nurses are rostered 24/7. Health and social care professionals at the Forsa conference, which I spoke at a few weeks ago, they were very up to it. And they said it'll need to be part of a contract negotiation. They're dead right. The consultant contract is now 6 days a week, and then it can be a Sunday by agreement, but rostering 6 days a week. So we're moving there, and Shane, we have no choice.
No,
we've no choice. We have to have a 7-day week system.
I think anyone who's been in an emergency department over a weekend will totally agree with that. Sheila, can I bring you in? Can I get you to get your crystal ball out now and look into the future? The additional skills that nurses are going to need to talk us through some of them, because the world is changing at a frightening rate. I won't even, well, we've got this far without mentioning, I think you mentioned AI already, Minister, but I'm not going to be in a job apparently in 10 years. There'll be a computer or a robot here instead of me. Which might be no bad thing, some people would say.
Well, yeah, I mean, so regulators have to become more agile, and that's right across the board. If it's utility regulation, if it's big data, and if it's nurse regulation. So we have to understand and become much more porous about how we would expect nurses to be trained and midwives to be trained over the next number of years. So you have to, we're going to have to allow that flexibility, and then try to encourage the universities, obviously, to be at the races, if you like, in relation to providing that capacity. So one of the things we have done, we're the first regulator to do it, is we've created a digital competency framework, standards and requirements for the undergraduate program. So now we're expecting that digital competency will be reflected in the undergraduate program. Now, I mean, it's loose enough because we can't specify what that should look like in 5 years' time, but it is about bringing in AI and all of the points that the minister was making earlier about the future-proof and e-health and the digital interventions that will come. So that's one of the initiatives. There is a huge budget that lies with the HSE at the minute that allows for academic institutions to be engaged to provide training, so that we can pivot around training very quickly. And education, like register recognized education at level 9 for initiatives. So if something becomes the new big problem, even like COVID, obviously COVID was a huge obstacle, but other things that appear, diabetes, neonatology, all the issues that may well present over the next number of years and become more prevalent, that we can quite quickly and with agility pivot around to invest in that. So at a strategic level, I think the system is actually quite agile, but the regulators have to be much more liberal about allowing for the education to at least run in tandem with progress.
Okay, Orla, do you have anything to add on this particular issue?
No, I mean, other than to say the one advantage we have is that all of the young people coming into our systems now are digital natives.
That's right.
Yeah.
So, they grasp hold of technology far quicker than we might. And so the limiting factor, if there is one, is the availability of material to teach. So we need really, really well-equipped simulation labs. We need clinical skills labs so that students can use technologies. They can interact with AI and machine learning algorithms in order to speed up diagnoses, to help them work through differential diagnoses. I think the one huge advantage that AI offers is the ability for us to hone those skills of critical thinking in our students, so they'll be far more proficient practitioners when they leave us.
Stephen, on a wider level, how do you prepare students to work in a digital health environment?
So I suppose as part of all our curricula in UCC, we have our graduate attributes program, or GAP program, where all students self-assess their digital competencies at the point of entry and at the point of exit. So we give the students the opportunity for that greater exposure to digital competencies. But in the healthcare professional programs, I suppose we use simulated laboratories, we use artificial intelligence on dose prediction, excuse the jargon here, but in our pharmacokinetics and our pharmacogenomics laboratory calculations, that's all artificial intelligence, where you're using actually, I said jargon, but I suppose we have been using modeling, mathematical modeling, statistical modeling on data for years to identify groups of patients that should be targeted to receive care. And that's where we can use artificial intelligence now to identify groups of patients, be it the elderly, be it those on polypharmacy or multiple medicines. They are the targets, and we can use these data sets so that we can then prioritize those patients for medication reviews or interventions from the healthcare professionals. Okay. So that's the type of training that we're providing across all the healthcare professionals. And we do that through interprofessional learning education sessions with the professions working with, from, and learning with, from, and about each other in patient simulations settings.
Okay, Minister, I know you're kind of quite up to speed on sort of tech matters. Is there a sort of excitement about the potential for AI in terms of transforming the health service a little bit? Is it something you've even had time to give thought to?
Yeah, there's a few things happening at the same time, which I don't think healthcare is going to look anything like it does today in 10 years' time. So I was in the Texas Medical Center last year around Paddy's Week, the biggest healthcare campus in the world. And I said to the guy, in 10 years' time, what's the biggest change we're going to see? And he said, personalized medicine, genetics, right? So he said, cancer. He said, we'll have your genetic profile, we'll have your genetic history, we'll have sequenced your DNA, we will know how likely you are to, and when in your life you're likely to, your cells are likely to start going off.
Yeah.
We'll be keeping an eye on you. And he said, we'll be able to tell years ahead of your cells turning cancerous, that they're at risk of turning cancerous. And we will then be able to give you a medicine that has been designed for you, for your body to go and deal with that, right? So that is extraordinary. We now have this thing called CAR T cell therapy for children and adults. And when the commissioner, Kyriakides, was here, we brought her up to James's, right? So this is a cancer treatment where they take a pint of your blood, they suck out the white blood cells, they send it off to Germany, they do fancy things to it in Germany, they bring it back and they stick it back into your body. And then we stick you in an isolation room for about 4 weeks. And what happens is the cells go back into your body. Apologies to all the people who actually know what they're talking about here. I'm okay. And
Just look at me, Minister. It'll be fine.
I'm good on the physics. I'm afraid I'm not so good on the biology. But as it was explained to me, your immune system completely reboots, and your antibodies, your blood cells, are now basically reprogrammed to go after the cancer in your blood and kill the cancer cells.
Wow.
Right now, it's only for cancers of the blood, and you only get it. We've only had it since last November. You only get it if everything else has failed. So I met a father of lovely young kids who was told in November of last year out of James's, you're done. You need to go home. You've probably got about 12 weeks left. You need to make yourself comfortable. And they said, but actually, we've just started this new thing. Do you want to go? He's in full remission and had just come in from playing a full round of golf. Now, that's not the exciting thing. The exciting thing is when I spoke to the scientists and the doctors and said, where's this going? They said, well, we're figuring out, obviously there's a massive global consortium working on this. They said, we're figuring out how to move from blood cancers to solid tumors. It's going to become earlier and earlier in the treatment. And they said, so where we're probably going with this is you get a lump in breast cancer or prostate cancer or whatever it is. We already have a healthy pint of your blood. We'll recode it in Ireland. We'll stick it into you, and it will go in and basically break down and gobble up the solid tumors. Wow. So where we're going is absolutely astonishing and exciting. But if we're going to do this, we in government need to fund and insist the HSE rolls out an actual e-health strategy. And by the way, this is not a criticism of the HSE. It is government who never funded the 2013 e-health strategy. So we're putting a new one together. It needs a vast amount of money. We can't expect digital breakthrough and tech-enabled breakthrough if we don't actually invest in the infrastructure in our own health service.
Fair.
And if I could add, we also need investing in research that supports that activity. So that whole precision medicine sort of spectrum that you've laid out, which is amazing and fantastic. We need to, those clinicians that we bring back, we need to give them time because they've been working in centres where they're doing this on a daily basis. So we do need that. And then we also need to bring the manufacturing of the CAR-Ts back here.
Yeah, absolutely we do, yeah.
Okay, we have about 10 minutes left. Does anyone have an absolutely burning desire to ask a question? Yes.
My name is Laura Zahn. I'm the director of the School.
Just right up, I think. Right up,
Okay.
yeah, you say.
For the third time, Laura Zahn, School of Pharmacy, UCC. I'm really excited to hear no, you're not a doctor or a professor, you're Stephen Donnelly, TD, speak about using the extent of the license of, for example, health and social care professionals. With my Pharm director hat on, I would love if you could comment on how I can now future-proof our curriculum with perhaps prescribing going into that curriculum. Could you perhaps speak to that?
Yes, I can. I'll tell you what I'll do is I won't presume to say how to educate the students because I'm in a room full of professional educators. What I can do is tell you where we're going. And then I think you can all figure out how to educate, how to change the education. So as you'll be aware, I think it's RCSI, is putting pharmacy prescribing modules together. that needs to become mainstreamed so that our pharmacists become prescribers. It's working very well in some other countries. We need to have it here. We have a bizarre system whereby medical card holders who want over-the-counter drugs have to go to their very busy doctor to get a prescription for over-the-counter drugs. That's barmy and it needs to stop, and we're working on that. Things like oral contraception. We need to be looking at that. Minor ailment schemes. So if somebody comes in with conjunctivitis, they don't need to go to see a GP. A pharmacist is more than capable of dealing with that. And so what we want to do with pharmacy is exactly what we want to do with every other profession, is get everyone working right to the top of their license. And as Orla said, in a multidisciplinary way. So my own view is pharmacists are we're probably utilizing about half their expertise right now. And same with advanced practice, right? So in the new world, we should have pathways for patients that don't just default to, well, you have to go and see your GP, right? You should be able to see a pharmacist or an advanced nurse in general practice, or a GP, obviously, when you need to see a GP. So I won't answer the education question, but I think that's where we're going. Yeah.
Can I just come in on that, being a member of the profession? But there's fabulous examples in iSympathy projects and in other projects where pharmacists and other healthcare professionals have been given roles in GP practices. They've been doing medication reviews, repeat prescriptions in tandem with the GP, working collaboratively together. GPs are very willing, they're very open, they're enthused about this expanded role, the expanding healthcare team in their practice, and we need to work with them to create those roles.
Okay, all right. We'll take one more quick question and then I'll come back.
Thank you very much. Sinead McMahon, Director of Clinical Education in UCD. I just wanted to bring you back to the HSCP roles, perhaps more so around capacity for clinical placement. So I understand from nursing colleagues and pharmacy colleagues that that's very well supported, and I know they still have issues, but certainly from a HSC perspective, the same capacity issues are, they're not addressed in a similar way at all for all of the therapy professions. So I would urgently urge you to address this. There's, great enthusiasm to increase our numbers, and we would love to be producing more graduates, but our big block is placements. We don't have enough tutors. We don't have any payment for accommodation for students out on placement. There's an accommodation crisis. We're sending them all over the country, and they don't have the same equity at all as the medical students or nursing students in any of the universities.
So I think there's a few things there. I think one has nothing to do with increased places. It's just a comparison of different groups, and you're absolutely right. There are different rules applied. When it comes to training places, let me be categorically clear. Any number of additional places that the universities make available this year, we will have training places for. The response to the EOI was, to call it minimalistic, would be kind. Like there were some where it was proposed there were an extra 2 college places for mission critical people. Any number of extra college places that the sector comes up with, we will support. As Sheila has said, she's provided, they've already put in place for nursing enough for a 20% increase in college places this September, right? So for the number of health and social care professional roles, sorry, I fully accept it's far more complex, right? I'm not saying it's easy. Nursing in a way is easier because there's established infrastructures there. And to be honest, in nursing, most of the placements are between 9 to 5, Monday to Friday, 6 months of the year. You can do 12 months of the year. You can do weekends, you can do nights. In fact, some of the training nurses said to me, they'd love the students to be in at nighttime because there's less doctors around, and actually you get a much richer experience in terms of clinical care and training. So I fully accept that it is more complex with the health and social care professionals, but I can assure you that any number of places you come up with, we will have training places available for.
Okay, solid commitment there. We just have a couple of minutes left. Yeah, we're okay for another few minutes. 2 minutes. Okay, so just maybe let's focus on a nice easy question to finish. How do we alleviate pressures on the healthcare system? Stephen, do you want to take that first?
The minister has mentioned some of them. I think it's expanding the roles, expanding minor ailment schemes, taking pressures off the emergency departments, the already stretched GP practices. We need to look at expanding the roles of physiotherapists, optometrists, and other OTs, speech and language services, to advancing the scope of people's practices. So that's one area. I think we also need to, as the Minister has said already, with Sláinte Care, working collaboratively, but also I think extending the hours of our acute services as well, moving to that 7-day-a-week model. They will take some pressures off.
Orla?
I would say this is an area that the Minister and his colleagues can lean more on the universities. We can provide continuous professional development. We can keep people upskilled with contemporary courses. And I think there's huge scope for us to expand the provision that we do to make sure that we keep our practitioners engaged, no matter what discipline they're from, to keep them up to speed, allow them to upskill, reskill, or change direction for their career.
Okay, Sheila, what about you? Can we learn from other countries, other systems, do you think?
Well, I don't know about learning, but we have to maybe depend on those other countries in the short term, because we have to bring in overseas nurses and midwives in the short term, and we have to find strategic partners. I think that's one of the things we can do, as opposed to just fishing with a wide net. If you like to get people, we need to actually find maybe key strategic partners internationally that we can work with to provide that short to medium term need, whilst we invest enough in our own system to get like what we call homegrown, professionals. So that is one of the things we can do, and we as regulators have to be proportionate about how we intervene in the health and the educational system to make it as efficient as possible, to make sure standards are maintained, but we're not scratching around looking for trivia whenever we could be doing a combined investigations into sites.
Okay, Minister, I know there's not one thing, if it was, so you wish there was, it was just that simple, but is the 7-day working week, is that the key thing for you as far as you're concerned in terms of alleviating pressure?
It's what I was saying in the speech, right? It's capacity and reform. The healthcare professionals, quite rightly, when I came into office, said we need lots more beds, we need lots more healthcare professionals, we need lots more diagnostics, we need lots more community care, we need an awful lot more capacity, and they were absolutely right. And we're doing that. But then there has to be this reform. Some of it is reform that is, like you say, nobody wants to work on a Saturday or Sunday, but we kind of have to move to that level. Some of it is that kind of reform that we all know we just have to get on and do it. Some of it is really exciting reform, like advanced practice and multidisciplinary practice and flexible working and more strategic partnerships with the universities. But there is no one answer. I think the difference is what we now have is a very clear idea of where we are going, right? We are cutting costs for patients. We're rolling out new services and making sure that they are excellent services and bringing in things like the Patient Safety Act and those things for patient experience. And thirdly, we are tackling the waiting list and the EDs. Ultimately, everything we do has to come back to the patient.
Okay.
Can they afford the care? Can they get the kind of care they want, and can they get it when they want it? And I just finish on this on an optimistic note, because everyone who works in healthcare lives in an environment of relentless negativity. It's relentless, the negativity. For every problem, there are probably 5 good things happening. But for every good thing happening, 5 bad things happening get talked about. And that's normal and it's natural. It's not a criticism. But it can be exhausting for the people working in the system to just hear negativity all the time about what they do and what they love. And so I think we have to be very ambitious. And I think we really have to back ourselves and say, in spite of all the challenges of COVID and in spite of all of the legacy deficits that are there is something really important happening in our public health service. And it all comes down to those working in it. It comes down to the people in this room, the people watching online, and our healthcare professionals around the country. They are in danger of fixing our healthcare service. And I think we really need to bear that in mind.
Okay, thank you, Minister. Ladies and gentlemen, a big thank you to Orla, to Minister, to Stephen, and to Sheila. Thank you, guys. Okay, can I invite Jim Miley, now Director General of the Irish University Association, to issue some closing remarks, Jim.
Thank you, Shane. I think the Minister's comment of the relentless negativity is one we would all empathise with and recognise. But I think what we've seen today are from the discussion are some strands of real positivity. And I guess if you were to do a word count of what was spoken today, I think the word collaboration is likely to win the prize for the most spoken term. And I suppose that's at the heart of this Future of Ireland series that we've been running now for a number of years. We're trying to, I suppose, look at the issues and challenges that our country faces and trying to look at what our universities can do to help with those challenges. And of course, as the Minister said, there's none more challenging than our healthcare system, which in many ways is the bellwether of a civilized society. So we've heard today about the need to supply more staff, and I think no surprise there. The Minister has outlined, the need to double, not just doctors and nurses, but right across the piece. Physios, public health specialists, social care, psychiatrists, psychologists. So I think the challenge there is quite formidable. But it's clear that our universities are ready and willing and able to do that. And I think we would particularly welcome the Minister's recognition that that can't happen without the appropriate funding. And he mentioned, the need that we don't need extra places for doctors. We need to shift some doctors' places from non-EEA people to EEA students, but that can only happen if the appropriate level of funding is put in place. And I think then we will find the universities will respond very quickly to that. But it's not just about more. I think as we've heard, it's also about the rapidly changing skills needs of the existing workforce. And again, I think our universities have already been providing, postgrad programs and a whole range of programs around that. And they're doing more. So next month, we'll be formally launching our micro-credentials program, microcreds.ie, the first platform of its kind in Europe. And what that is bringing together short-form courses, university accredited across a whole range, right across the spectrum, to allow our workforce to reskill and upskill. And already, I just looked before I came out, on the platform is live at microcreds.ie already, although it hasn't been formally, hasn't had the ribbon formally cut yet. But there are already 63 healthcare and medicine courses up on the website to start from this September, mostly in the 6 to 12 week part-time range. And that, I think, we hope that, and there certainly is an ambition, and the project director is here, Jules O'Connor, there is an ambition to double or more the number of courses over the next year in that space. So I think that's an example of what universities can do. And that is the micro-credentials program is a government-funded initiative under the Human Capital Initiative. So I think, again, the collaboration message is to the fore in terms of what we can deliver there. And of course, we also heard then about, not just about the places and the upskilling or reskilling, but the clinical placements issue, which I think was spoken about at some length. And we've heard the issues there around the need for not just for the places, but for the tutors and the capacity within the system to make that happen. So I think what we've had, I think, is a very thorough and fulsome discussion. I think we in the university sector recognize and I suppose actively live on a day-to-day basis the collaboration that's required with government, with state agencies. And there's one thing, I suppose, that we all learn about collaboration. You can never have too much of it. And we certainly don't have enough of it when it comes to the future of healthcare skills. And I think we need to really work on that into the future. So all that remains for me is just to say thank you, firstly, to the Minister in what, as Shane outlined at the outset, is undoubtedly one of the most demanding roles in government, to give us his time today and for, I think, his very forthright expression of the issues from his perspective. And to our panel, Sheila, Orla and Stephen, I think for a really good discussion. The IUA team, Leah and Kate, principally, who made all this happen and who continue to make it happen on a continuous basis, albeit the last time Kate will make it happen because she will shortly leave us, sadly. to the hotel and technical staff here for again, the event here in the room, but also for bringing it out to the wider audience. We had well over 300 people between the people in the room here and our virtual audience. And I'd like to thank you on a sunny day for coming out, or for sitting at home in front of your or your office in front of your hotel, your PC to watch us today. And lastly, a big thank you to Shane for expertly steering the event. So Shane, do I hand back to you, or do I simply close it out? Well, on that basis, we'll say goodbye. Thank you very much.